Turn it over to you guys. Thanks.
Can you see my slides okay?
Sure can, Seth. Thanks.
Awesome. All right. These are just our CME slides here that I'll go through. No disclosures. All right, so the title of my talk is I Heart ID. It's Natasha. So this is a 77-year-old woman who's presenting with left eye pain and swelling. She was in her usual state of health, and then 4 days prior to presentation, she felt a foreign body sensation in her left eye. She noticed left eye redness and worsening blurred vision in that eye. She's now had constant 6 out of 10 stabbing-like pain in the left eye with an associated headache. She's also noticed a rash over her left eyelid around the time that her eye pain started. She's been scratching a lot around her eye, and now she cannot see and is unable to open her left eye. She now has any fevers, chills, joint pain, no trauma to her eye, no animal or insect exposure that she can recall. In terms of her past medical history, she has bilateral cataracts that have been extracted, and she has intraocular lens in place. She has suspected glaucoma, hypertension, arthritis, hyperlipidemia, asthma. She had hydrochlorothiazide, amlodipine, lisinopril, and albuterol inhaler at home. She has no known allergies. She moved to Maryland from Ghana a few years ago. She lives with her daughter in Maryland now. She doesn't have any outdoor exposures, no recent arthropod bites or other outdoor exposures that she can recall, mostly stays indoors. And then in terms of her physical exam, so she's a little hypertensive. Her pulse is slow at 50. She's afebrile, breathing well on room air, and this is what her eye exam looks like. So everyone's take a look at that for a minute. This is her slit lamp exam, copied from what Otho did. We'll talk about the left eye, which is where she's having the vision loss and is most remarkable. So she has some lesions over the upper and lower eyelid margin. She has loss of the epithelium of that eyelid. She's got some diffuse injection and some mild hemosis in the conjunctiva. Then there's some diffuse large granulomatous mutton fat, KPs, which are keratic precipitates involving the central inferior half of the cornea. Mild edema with trace D folds. In her interior chamber, there's 2 to 3 plus cells with 2 plus flare. The iris looks normal. And then her lens, so she has posterior chamber intraocular lenses that are intact with some pigment interiorly. And then the vitreous looks, there's some trace cells, there's no real haze in the vitreous. And on the right eye, that is notable, there's a posterior vitreous detachment on that eye, and some meibomian gland dysfunction and arcus that was seen. So, given these findings, it was recommended to her to get an MRI of her orbit. This is just a picture of what mutton fat KPs look like, which we'll talk a little bit more about, but that's just a close-up. In terms of labs for her, she does not have a leukocytosis. Her labs are pretty unremarkable. Her BMP was really unremarkable. It's got a little bit elevated creatinine. That was close to her baseline. LFTs look normal as well. So she was heading down to go get an MRI, and they got an EKG beforehand because she was pretty bradycardic, and this is what her EKG looked like. Everyone take a look at that. All right. What is our differential diagnosis in this woman?
Well, thank you, Seth, for sharing the unusual inclusion of an EKG and ID conference. Always good to include that. So I will, let's see, Dr. Ashwin Balagopal, are you available to discuss the case?
Yeah, I can try. I mean, other than having eyes, I have no expertise in this area. So the EKG, I think you hurt me with that, Dr. Judson. I'll do my best.
All right.
So this is a 77-year-old woman originally from Ghana with, sounds like diabetes, hypertension. I think I missed that part. Who has several week onset of left eye pain associated with a rash, progressive pain that that seemed to be associated with a host of findings throughout the chambers, but really in the vitreous. You didn't mention anything about the uveal tract per se, but I'm assuming that this includes the possibility of a granulomatous uveitis, and then what looked like first-degree AV block. You will have to. I thought I saw P waves before every QRS complex, but with an interval of more than 200 milliseconds. Would that be? I think it matters whether it was complete heart block or not. That's why I'm asking.
Yeah, it was actually complete heart block.
Oh, it is.
Yeah,
Okay.
so there is complete AV dissociation there.
Wow. Okay, so I guess in terms of discussion, that prompts sort of three sets of thoughts. One is, or at least two distinct sets of thoughts. One is the differential for eye problems, and the other is the differential for heart problems, and hopefully there's some overlap between the two. And then the reason why I say third is because she is, from a region of the world which is considered developing, and so there may be some overlap with some of the items on that list of organisms. I think I'll start with what I think is the smallest list that I'm aware of, which is the granulomatous eye things, and I would include things like toxo, syphilis, TB, possibly sarcoid in that list. And I'm sure there are more, but it's the smallest list because it just it exceeds my knowledge base. Of course, when there's an external rash associated with an eye problem, it does make you think of acute retinal necrosis, VZV associated or progressive outer retinal necrosis. It's a regrettable acronym, but I don't. That's usually a retinal problem, and not that there can't be overlap, but it's just doesn't seem like that would be associated with the kind of precipitates that you would have here. But there is something cloudy on the lens, so while we're on BZV, I would include HSV. I think it's probably worthwhile to also include endocarditis, because of it sounds like there were only very vague vitreal precipitates, but that makes you think a little bit of endophthalmitis, and so of course endocarditis you would be able to link endocarditis to the heart as well, with a particular class of lesions. So I'm going to stop on the eye stuff for now, and I'll move on to the heart stuff. I think I would, of course, consider Lyme disease, but I can't really wed that diagnosis to the eye findings here, not elegantly. I would, I think it's an RCA embolism, an infected RCA, an infected embolism to the RCA can lead to AV nodal problems. That's a severe issue, which I don't think that would present just with some bradycardia. I think that would present with signs and symptoms of ischemia. But perhaps a coronary artery aneurysm from syphilis. So syphilis makes the list twice, I guess. Let's see, what other heart things could lead to principally an AV nodal block? This isn't, I don't think this is right, but of course Chagas can lead to heart issues, mostly cardiomyopathy, and I guess it's probably been known to be biting near the eye, but other than that, I can't, it's not really the right, the finding. Someone mentioned nocardia, but nocardia, I mean, to my knowledge, it doesn't, despite its name, it doesn't really involve the heart much, right? I mean, I think it is named after that French guy, Nocard, but I believe there is nocardia endocarditis occasionally, but it's not a common presentation of nocardia. But I'm happy to be corrected. Let's see. I think I'm just sort of out of luck here. I don't know what else I guess I would say something like a preseptal cellulitis or an orbital cellulitis, and I think I would probably include sagittal vein or cavernous sinus thrombosis in the setting of a systemic disease like endocarditis, which can lead to chemosis. When people say chemosis, it often makes you think of leptospirosis, but that's usually bilateral, and you might have more of a presentation with elevated LFTs. This patient's chemistry and liver profile seem pretty sterling. I think I just need help. I mean, I can just keep going, but I think I would benefit from someone who truly is expert in this.
Marvelous list, Ashwin, and I like how you wrapped it around the specific aspects of the patient's presentation. We will open it up for additional thoughts or considerations, and Dr. Cheetah, I'll ask you to read those out if you wouldn't mind.
So I think Robin is just pointing out that perhaps there was primarily a VZV infection that got secondary infected with Staph aureus. So I'm going to add Staph to bacteria here. And then, and maybe cornea involvement from scratching. And Staph perhaps involving the aortic root causing complete heart block or an aortic root abscess. Punita's noting that she's not an eye expert, although to me she's an expert in all things, but wondering about Toxocara, which we'll add to the list. And I don't know how this would be involved with the heart, but I'll just add Loa as well. And Trish is adding Onchocerca. Again, not sure how that, we're all confused about this heart issue, Seth, so that better be involved here. Other thoughts from the group? Gotta slow down. I will say, Ashwin, I think this is the most potential processes we've seen in a long time. So I think speaks to the difficulty of this case. Vicky is adding acanthamoeba, which out of pure laziness, I'm going to put under parasite just because I don't feel like making one category. Right. Any other takers? I'm going to count down to 3, 2, 1. And so now Michael is working on making the online poll, but we can poll our audience here, our intrepid in-person group.
Oh, let's interrupt one moment, Natasha. Sorry. Dr. Judson, do we have the answer on the board?
Yes.
It's on the board.
Yay.
Great.
Good point. Okay, so I don't even know where to start, so I'll just go really fast. Okay, anyone for syphilis? Okay,
So
got it.
folks on Zoom, you will see a poll here momentarily. For Zoom-based polling, you can only have 10 answer choices per question. So the pathogen choices are split over 2 questions. So there's 1 process question to answer and then 2 pathogen questions. Okay, back to you, Dr. Cheetah.
Syphilis, TB. Well, not here, he's not raising his hand for TB, which is always a good negative predictive value. Borrelia, Nocardia, Lepto, Staph. I'm going to stop now since there's only like 3 people who have voted. What do you guys want? No, shaking their heads. Okay. There's 100 votes for syphilis in the room. 300.
Okay, sounds like a packed house then in Cater with multiple votes for syphilis. Thank you, everyone there for voting, and thank you, Natasha, for putting the whiteboard together and for gathering the votes. and for others for adding diagnostic considerations. We have a good number of folks who have voted here online. Just wait another few moments for everyone to sort through. All right, I will end the poll here. And so folks should see now in terms of the most likely process, endocarditis with endogenous endophthalmitis was felt to be most likely. As you can see, with a few other considerations, retinal necrosis, coronary artery aneurysm, or an orbital or preseptal cellulitis getting consideration. In terms of a pathogen, about half of the online audience voted for syphilis, with Staph aureus coming in second place, and then a number of others, TB, the herpes viruses, Lyme, and Chagas getting some votes. And then there was a host of parasites mentioned at the end, and of those, if you were to pick one, Toxocara felt most likely. So Seth, very interesting. Thanks for sharing the case, and look forward to your discussion here.
Thank you, everyone. And was a great differential diagnosis, and really interesting to think about how we connect this eye and heart manifestation together. So, let's see. So in terms of diagnostic studies, so Ophtho sampled the anterior chamber. It was VZV positive in the anterior chamber, HSV negative, CMV was negative. Serologies that were sent were also negative. HIV, the patient didn't seem like they were significantly immunosuppressed. Syphilis was negative. Heat spot was negative. Although their Lyme disease antibodies that were sent were equivocal. 3 of the bands were positive, so it was in the equivocal range, which we'll talk a little bit more about. So on the first day, they were started on 1,000 milligrams BID of valcyclovir by Ophtho, put on prednisolone eye drops out of concern for VZV anterior uveitis. But cardiology was the one who admitted the patient to place a pacemaker because they were in complete heart block. On the second day, they were noted on their Ophtho exam that the left pupil was non-reactive and dilated. So they consulted neurology, put them on pulse dose steroids at that time, and then they had a transvenous pacer that was placed. We were consulted on the third day of admission, switched the Valtrex to IV acyclovir, given concerns for more severe infection. And then was also started on IV ceftriaxone with this equivocal Lyme disease positivity for possible Lyme carditis causing complete heart block. Then a dual AV pacemaker was placed on the 4th day. Because they had a repeat Lyme disease serology that came back negative, and the patient really had no exposures that seemed consistent for risk for Lyme disease. We ended up stopping the treatment for that. And then their vision improved just on 4 days of treatment. On the 5th day, they were able to finally get the MRI brain in orbits, and there was some mild asymmetric enhancement of the left orbital optic nerve sheath concerning for perineuritis, but not optic neuritis. And then interestingly, the EKG had return of her native sinus rhythm, which is, I think, kind of the most interesting part of this case. So this is her initial EKG. She was in complete heart block. As you can see, there's complete AV dissociation between those P waves and the QRS complexes. This is her EKG 2 days after she had her AV pacemaker placed. You can see there are pacer spikes in some of the complexes indicating that she's being paced. But she does have some return of native rhythm when she's not being paced. So she's not being completely paced. She was, when she had the temporary pacemaker placed, like the 1st and 2nd day, she was being completely paced all the time at 60. And then when they put in her AV, by the time they put this in, and then a few days afterwards, she started to have some return of her native rhythm. And then by the time she was discharged, she had pretty much complete return of her native rhythm and was not being paced. She does have this right bundle branch block, but otherwise was not being paced and just had normal rhythm. And this is what cardiology commented on as well. So pretty interesting. She had resolution in her complete heart block. So our patient, so we have a 77-year-old woman from Ghana who's found to have VZV anterior uveitis, perineuritis, and then resolving complete heart block. She completed a 7-day course of acyclovir and then prednisone eye drop taper, which improved her vision. Just a little bit about herpes zoster ophthalmicus, because this is what she had. So herpes zoster ophthalmicus is a reactivated VZV infection involving the ophthalmic division of the trigeminal nerve. It was interesting looking at this. It's actually a much higher prevalence than I previously thought in terms of patients who have herpes zoster and have complications with zoster ophthalmicus, about 8 to 20% of patients in some of the meta-analyses that I looked at. Possible complications. So there are many different manifestations as well. I think we often think about the corneal involvement in the keratitis and thinking about having urgent opto evaluation, but uveitis, both anterior and posterior, as well as pan-uveitis. And the uveitis can actually be more of a delayed manifestation of the zoster ophthalmicus. Those mutton fat KPs that we're seeing that are signs of granulomatous inflammation. The cells that were positive in the anterior chamber were concerning for uveitis. Secondary glaucoma can also be caused by this. Cataracts can be caused. Lid retraction and lid loss, which she did have, can be associated with this as well. And then the neuroophthalmic manifestations like optic neuritis. She had perineuritis, so inflammation of the nerve sheath, but not necessarily full-on optic neuritis, scleritis, conjunctivitis. And so for the uveitis and treatment for this in general, valaciclovir, 1,000 milligrams TID or acyclovir 10 mg per kg Q8 for at least 7 days, and then having a topical steroid taper, which she seemed to respond well to. But the part of the case that I was more kind of interested in and thinking about are what are the reversible and infectious etiologies of complete heart block in this patient? And was there a way to tie together her eye disease as well as the fact that she had reversible complete heart block, which was kind of unusual. Just to review AV block and reversible etiologies. So most causes of AV block are ischemic heart disease. She didn't end up having signs of ischemia. She ended up having a normal echo. But 40% of all AV blocks were caused by ischemic heart disease. Electrolyte abnormalities. She did not have unusual electrolyte abnormalities on admission. Increased vagal tone can be a possibility. Hypothermia, trauma to the heart. I remember seeing this on the cardiology service, like patients who were in the trauma ICU, had like a large trauma to their chest, could go into complete heart block overnight, and then it would resolve kind of in the setting of the traumatic injury resolving. In terms of medications, so lots of antihypertensives, beta blockers, calcium channel blockers, clonidine. For medications, we didn't really think we're driving this. Antiarrhythmics, which she wasn't really on, but adenosine, digoxin, amiodarone. Some other medications like benzos or TCAs, antipsychotic medications, anticholinergics. These don't seem to be implicated in her case as well. And then toxic etiologies like cocaine or alcohol or phosphates, traditional medicine. So those are kind of the main non-infectious etiologies of complete heart block. But what are the infectious etiologies of AV block and reversible AV block? So Lyme carditis is one that we'll talk about and was relevant in the setting of this case in terms of thinking about her risks. Group A strep and rheumatic fever. Trypanosomiasis, so Chagas disease, known for causing a cardiomyopathy, but can also cause AV block and conduction abnormalities. And then something I was interested in, because she was from Ghana, was human African trypanosomiasis, which is less associated with cardiac disease, but I was just curious, and I'll talk a little bit more about that if there is any evidence for that, given both these trypanosomes. Myocarditis, endocarditis, like we talked about, again, her echo looked normal. And then viral infections, I think we all are aware of this now with SARS-CoV-2. And I remember early on in the pandemic, one of the first patients that we had seen in Seattle ended up having a complete heart block that then resolved. There's a lot of literature on the cardiac manifestations of SARS-CoV-2, but other viral infections can cause AV dysfunction. So in terms of Lyme carditis, so this was interesting for me coming from the West Coast that I did not know as much about, and it was interesting to learn about. And it's a great part about being here for fellowship to work with experts in this area. So it appears during the second phase of the disease, about 1 month or so after the tick bite, and that's kind of in the early disseminated infection of Lyme disease. Presentations include conduction system disturbances. Most common is AV block, myopericarditis, pericarditis, and myocarditis. Most infections and cases of high degree AV block resolve in about 1 to 6 weeks. And treatment for a high degree, like complete heart block, is IV ceftriaxone, which she was empirically started on, so the equivocal of Lyme disease serology. Otherwise, doxy or amoxicillin, and usually 14 days of treatment. There's a great article by Drs. Robinson and Amelia from Hopkins about Lyme carditis that I referenced. I like this image a lot, the graphic here showing the different areas where Lyme disease can affect the heart. And as you can see, the most commonly affected section is the AV node in terms of the conduction system. But there are other like rare reports of AFib or valvular involvement, the bundles, pericarditis. So most commonly though manifests as AV block, and it's readily treatable with antibiotic therapy and supportive measures. Temporary pacemaker placement might be needed for some patients who have really high degree AV block, but it's a permanent pacer is not recommended because it can be treated with antibiotic therapy. This is a great article to look at. One of the things that they also comment, just looking at the incidence of this is something I was interested in, but 1.1% of Lyme disease case reports to the CDC between 2001 and 2010 included cardiac manifestations. Patients who developed Lyme disease related to complete heart block may first manifest degrees of AV block with a median of 14 days, which is just interesting to know in terms of thinking about the timeline and the onset of their symptoms. But one of the other parts, and I think, and I got to credit Dr. Nuremberger for recognizing this, is that VZV is actually associated with heart block. Very rarely in their case reports of this. And this is something that we thought a lot about in the terms of our patient. So VZV was first recognized as a possible cause of myocarditis in the 1950s. Supraventricular and ventricular arrhythmias have been documented in infants with VZV, so maybe we can talk to our pediatrics colleagues a little bit more about that if they've seen any cases like that. But there are multiple case reports of heart block in the setting of acute VZV reactivation in adults. And there's actually this one really interesting case report where they take the timeline from symptom onset and they trace their heart rate and their bradycardia. And as their zoster pain and their symptoms progress, their heart rate slows down more and more, and they actually go into complete heart block, but that then self-resolved kind of during treatment for zoster. Proposed mechanisms for VZV include infection in the cardiac nodose ganglia. So the nodose and the celiac ganglia are areas where theoretically VZV could reactivate and potentially lead to heart block. And those are areas in addition to the dorsal root ganglia, which we know where VZV tends to reactivate from. And then this was this kind of deep dive I did into this on just as interest in terms of cardiac involvement in human African trypanosomiasis. So there actually is literature on this, and it's something I think that warrants further investigation. So we know that the conduction problems are more often seen in acute Chagas disease cardiomyopathy than in human African trypanosomiasis. But in cohorts of patients with human African trypanosomiasis, cardiac involvement can be seen by EKG changes, such as repolarization changes, low voltage, but cardiomyopathy is rare, and complete heart block is also very rare. It's also cardiomyopathy that is associated with human African trypanosomiasis is generally benign, does not cause like relevant congestive heart failure, and usually subsides with treatment. There's an interesting cohort in this paper from the Lancet where they looked at patients with West African human African trypanosomiasis, and 71% of the patients had EKG changes, and this was actually similar to the frequency of involvement in a separate study looking at histological postmortem studies in patients. And then there was a case report in this study kind of looking at a patient who developed complete heart block. So I think it's something we often don't really think about, but that was interesting in terms of the patient being from Ghana. I'm thinking about that a little bit. So in summary, some key points from this case, herpes zoster ophthalmicus has multiple manifestations and higher prevalence than I previously suspected. Multiple infectious etiologies contribute to reversible complete heart block, which I think is really important in our differentials. I think some of these patients we think are primary cardiac, ischemic type etiologies, but actually infection does have significant degree of disease burden contributing to reversible complete heart block. High suspicion and low threshold to treat for Lyme carditis, especially in endemic areas like here. And cardiac involvement in VZV and human African trypanosomiasis, I think requires further investigation. It's an interesting topic for further conversation. So thank you all. Happy to answer any questions.
Thank you, Seth. Fascinating case and a superb discussion. Really appreciate it. Wonderful discussion of this very interesting case. I think in the interest of time, we will ask to transition to Joe, just so we can aim to end on time. Just going to, while you are transitioning slides, just going to stop this recording so we can post this case individually.